Hello, my name is Valeria Oñate. I will talk about therapy clearance of amyloid by antibodies to serum amyloid B component. Introduction. The amyloid fibril deposits that cause systemic amyloidosis always contain the non-fibrillar normal plasma protein, serum amyloid B component sub. In mirroring amyloid A-type amyloidosis, the binding of these antibodies to the residual sub in amyloid deposits activates complement and triggers the rapid clearance of amyloid by macrophage-derived multinucleated giant cells. Methodology. We conducted an open-label, single-dose escalation phase 1 trial involving 15 patients with systemic amyloidosis. After first using CP-HPC, the depleted circulation sub, we infused a fully humanized monoclonal immunoglobulin G1 anti-sub antibody. Patients with clinical evidence of cardiac involvement were not included. Specific reasons, organ functions, inflammatory markers, and amyloid low were monitored. Results. There were no serious adverse events. Infusion reactions occurred in some of the initial recipients of larger doses of antibody. Reactions were reduced by slowing the infusion rate for later patients. At 6 weeks, patients who had received a sufficient dose of antibody in relation to their amyloid load had decreased liver stiffness as measured with the use of transient elastography, a reduction in kidney amyloid load, and shrinkage of amyloid lesion lymph node were also observed. Analysis. Current treatment consists of support or replacement of failing organs and measures to reduce the abundance of the amyloid fibril precursor protein. A sufficient reduction of precursor supply arrests the accumulation of amyloid and can reduce morbidity and mortality. However, amyloid regression is very slow and often does not occur at all, in contrast to the usually swift clearance of other extracellular debris and efficient tissues remodeling, for example, after trauma. There are no effective therapies for most hereditary forms of systematic amyloidosis. New treatments are required to improve organ function by eliminating systemic amyloid depositions. We report on a clinical trial of such a treatment which was designed to engage potent normal phagocytic clearance mechanisms. It involved the use of a small molecular drug, CP-HPC, the depleted circulation serum amyloid B component sub. Conclusion. Treatment with CP-HPC followed by an anti-sub antibody safely triggered clearance of amyloid deposits from the liver and some other tissues.
What is really exciting that we found that daratumumab, which is a drug that was developed for multiple myeloma and is approved for multiple myeloma, is very active in AL amyloidosis. So even as a single substance, it achieves high rate of remissions, and I presented data from Dr. Kaufman, who showed that around 80% of the patients go into a deep remission who are receiving daratumumab for AL amyloidosis. Deep remission means complete remission, or VGPR, very good partial remission. What is also very exciting that this drug induces a response very fast. He showed nicely that patients who received daratumumab had a complete resolution of their abnormal free light chains within 1 to 2 weeks. So this is very important for amyloidosis, that you have a deep response and a fast response. So based on those encouraging data, Janssen started a clinical trial, a randomized phase 3 trial with around 360 patients, in which Cybo-D versus Cybo-D plus daratumumab are compared. And if this trial shows that Cybo-D plus daratumumab is superior to Cybo-D alone, probably that will change our treatment approach, and patients with AL amyloidosis might be treated with Cybo-D daratumumab. I also emphasize that transplant is still very important, but that despite we have very potent drug, like Velcade, for instance, carfilzomib, and also daratumumab for the treatment of amyloidosis, there's still the problem of lack of organ response. So even when you achieve a complete hematologic remission, it takes around a year, a median, before patients show an organ response. That means before the body is able to break down amyloid in the kidneys or in the heart. And I spent, I would say, 50% of my time really in deciphering what is new in terms of anti-amyloid drugs. So basically, after the failure of NEOD-001, we have 2 drugs left. We have an anti-SAP antibody left, that's from GSK, and is currently tested in clinical trials in the UK. And we have KL101 as an antibody that targets directly amyloid, and a trial with KL101 will probably start in 2019. Both of those drugs, the SAP antibody and the KL101, showed very encouraging data as in phase 1 trials. But again, we have to show in phase 3 trials and randomized trial really whether those antibodies are able to break down amyloid. In addition, we also had a little bit an outbreak of TTR amyloidosis. So TTR amyloidosis is usually not treated by patients, by physicians, by hematologists. Usually TTR amyloidosis is treated by cardiologists or by neurologists. But we have two positive clinical trials. One led to the approval of parisotide. It's an antisense transthyretin drug that showed improvement of the neuropathy in patients with hereditary TTR amyloidosis and received FDA approval. The other drug is Therapeutic, that is a stabilizer of TTR, and a randomized trial showed that it increases significantly overall survival in patients who are treated with Therapeutic. So this is a positive encouragement that we should continue to work on the anti-amyloid antibodies despite we had the failure of NEOD-001.